Good morning, everyone. We are Group 3 and we are here to present an assessment on health programs against schistosomiasis. So, in this presentation, we will discuss two different interventions to combat schistosomiasis, namely MDA and the more recent NSEP. And we will compare both the positives, limitations, and whether or not the newer NSEP has solved the problems that were faced during the elimination of schistosomiasis in the Philippines. So first, let's discuss what is schistosomiasis. Well, it's an acute parasitic disease caused by a subset of flatworms from the phylum Platyhelminthes called blood flukes, and they come from the genus Schistosoma. So the disease is widespread and reported endemic in 78 countries in 2023, affecting 240 million people. In the Philippines, it affects at least 2.5 million people directly and puts over 12 million people at risk. And schistosomiasis is often considered as the most important waterborne parasitic disease. So, in terms of health effects, it can cause long term complications in the hepatic system or the liver and the kidneys, as well as being able to contribute to bladder cancer. So for the epidemiology or where it can be located, schistosomiasis is endemic, meaning it's found commonly in specific regions, particularly in tropical and subtropical countries like the Philippines. As for transmission, the main method of transmission is through infected waters, and an important secondary form of transmission is through virus intermediate hosts like dogs and water buffaloes.
With us now defining what schistosomiasis is, we now have the following question. What measures have been taken to minimize schistosomiasis in the Philippines? And what is the progress per determined program?
So let's quickly go over some previous treatments that were used for schistosomiasis over the decades. In 1944, we saw the introduction of antimonials, Fodit and tartar emetic, which were used for treatment of schistosomiasis among US soldiers in Leyte. The drug efficacy here was 31%, which indicates low effectiveness when tested in hospitals in the United States. In 1953, the Schistosomiasis Control Pilot Project was implemented in Palo Leyte with the WHO and used 9 intramuscular injections, which were later increased to 10 and 15. The respective cure rates are the following. For 10 injections, it was 61.2%. For 15, it was 86.7%. However, the proportion of cured patients dropped to 38.3 and 48.6% respectively 6 months after the injections. With this, major side effects, including pain at the injection site, dizziness, vomiting, body weakness, nausea, anorexia, and joint and muscular pains are also present. Therefore, in 1960, the use of other drugs, parasonylene pamoate and sodium antimony dimethylcysteine tartrate, were used. For parasonylene pamoate, it was safe and effective, but it did take 203 days to treat, and 3 to 4 capsules were taken 3 times per day. For sodium antimony dimethylcysteine tartrate, patients suffered from severe adverse reactions, including myocardial toxicity, which was present in almost half the patients. With this, the government had to come up with a different strategy, and one of the proposed strategies was mass drug administration, or MDA. So, what specifically is MDA? Well, it's a campaign to control, eliminate, and eradicate neglected tropical diseases through the widespread administration of medicine to all people in a community. It is being implemented, or was being implemented, as the primary mechanism to combat the proliferation of schistosomiasis. And despite this, its effectiveness is being challenged by multiple studies to this day. So when we talk about MDA for schistosomiasis, the main drug is praziquantel. So praziquantel is a antihelminthic used to treat infections caused by parasitic worms such as flatworms, flukes, tapeworms, and roundworms. So PZQ specifically is an oral antibiotic drug that acts against a broad spectrum of flukes and tapeworms. It's predominantly used in treating schistosomiasis, as it paralyzes the parasite, expelling it from the body. Its side effects are minimal, and it can also be used to treat preschool-aged children and pregnant women. The MDA of PCQ has been ineffective in certain areas in the Philippines nowadays due to the development of antibiotic resistant strains of schistosoma. So let's quickly go over how PCQ was developed and introduced to the Philippines and how it went from case finding to the MDA that we know today. Well, in 1979, we saw the introduction of PCQ in the country in a three-phase preliminary clinical trial on the tolerance and efficacy of the drug, which was done in Paula Leyte. In the first phase, it used different dosages, either single or multiple, to assess cure rates among patients. And this saw a range of around 71 to 80% at 6 months post treatment, with a drop to 54 to 76% after 12 months. And at this time, there were high incidence of adverse reactions such as abdominal discomfort, diarrhea, fever, drowsiness. In phase 2, we saw again different dosages of PZQ that were conducted and around similar cure rates of 70.7 to 80%. However, in phase 3, this is where we saw a dosage of two doses of 30 milligrams per kilogram PZQ being used, and here the cure rates were 84.3 to 97.4%. However, the severe and adverse reactions were still at 1.3%, which caused concern as being an effective drug for MDA. Also in 1979, we saw the Schistosomiasis Control and Research Services, or SCRS, observing the effects of chemotherapy using PZQ on the transmission of schistosomiasis. So, in this research, stool examinations were done in villages to test for the decrease in infection. And repeated selective mass treatment showed significant impact on the disease prevalence, morbidity, and transmission. Moving on to 1981 to 1989, it was a study of long-term impact on PZQ. So here there was annual screening and treatment of schistosomiasis infections using PZQ, and it showed that the prevalence and incidence of infection dropped dramatically after 3 years. So the community-based chemotherapy with PZQ, however, was unable to completely eliminate schistosomiasis. They concluded that this could result in a rebound of prevalence, intensity, and morbidity of schistosomiasis. In 1995, we see that the Philippine National Schistosomiasis Control Program received a loan from the World Bank. Here, the goal was to increase to 95% case finding and 100% treatment. This would focus on first finding where schistosomiasis was evident, then PZQ being used in that specific area to treat the disease. So there was a decrease of prevalence from over 10% to less than 5% in 1995. And in 1996, we finally see the shift from case finding to MDA. This was due to a decrease in funding. So instead of looking for specific cases wherein schistosomiasis was prevalent, simple parameters were used to decide where to administer PZQ. If the prevalence was greater than 10%, every MDA for everyone above 6 years old was administered. This carried on into the late 2000s with minor revisions from the DOH. In the long term, the community-based program implemented in Leyte showed a drop in the prevalence of the disease from 12 to 6% within 5 years from the start of the control program. It showed that PZQ treatments show impact on the morbidity associated with schistosomiasis. Overall, we can say that MDA did increase the control of morbidity compared to the previous drugs we talked about. This was much more efficient as the cure rates were higher and the side effects eventually became more minimal. We cannot deny that the drug worked, and it does in fact continue to work as an important method to control and cure the transmission of schistosomiasis. However, the biggest limitation is that MDA itself cannot eliminate parasitic infections like schistosomiasis. PCQ as well may be inexpensive, but giving annual treatment to the 12 million people at risk can be costly, especially in a country like the Philippines. And in addition to this, in the studies, the patient compliance, even for free mass treatment, was less than 50%. And in another light, the researchers in various articles concluded that human treatment is insufficient to end schistosomiasis. So, applying different health paradigms, how then can we evaluate the use of MDA with BZQ against schistosomiasis? Well, from the biomedical paradigm, we can say that the focus of MDA was too human centric, in a way that there was too much emphasis on trying to treat the disease with medicines than other causes that were largely ignored. So, the emphasis as well was placed on quantitative analysis, the main one being cure rate as a measure of effectiveness. This is basically the only thing that the whole research was looking at, and it essentially frames cure rate as the one and only way to assess the effectiveness of the program in its entirety. They didn't consider other factors such as distribution, awareness. Like no one cared about the human resources. Were there enough people? No one cared about the information systems. Were people being informed? Financing was brought up as one of the major problems, as well as service delivery. Were they all present? I don't think so. Yes, the medicine and technology was there, but if the rest of the systems weren't, then they cannot be effective. And the last point here would be over medicalization. The big question here was, did over medicalization of the problem scare the people? Is this why the compliance rate was so low? Is this why less than 50% of the people who were offered the free mass treatment didn't want to take it? Another way we can look at this is through the health politics paradigm, where the lack of coordination between the governments, institution, and the civil society may have had negative implications for control and transmission. So, in the articles, it was stated that there was a 1.12 million US dollar budget, and this is clearly not enough. This raises eyes on how important the government perceives schistosomiasis in the Philippines. Even as a key neglected tropical disease, why is it not getting more funding? Well, it might be in the word negligence or perhaps corruption. To this day, we still don't know. In addition to this, there's a lack of full time manpower. If people cannot step up to help, how can the problem be solved? Why is it we don't have enough people willing to work on this disease? Is it for financial purposes or is it because of the fear of the disease? And that brings us to our last point, the lack of knowledge by the civil population. How many people actually knew of schistosomiasis? Perhaps not a lot. And that then begs the question, why were people not aware of the disease? And who is to blame for this? This again goes back to what we talked about in the biomedical paradigm. Why were the compliance rates in the study so low? Even with the free treatment that was offered, why is this the case? Knowing all this, we can say that MDA with PZQ does have a significant impact on the direct intervention of schistosomiasis morbidity in humans as of 2015. However, it was still regarded as an incomplete solution to the problem. Schistosomiasis still remained a relevant disease across the country. Therefore, different interventions had to be made, and alternative solutions had to be implemented. With this, the National Schistosomiasis Control and Elimination Program, or NSCEP, was developed.
The National Schistosomiasis Control and Elimination Program, NSEP, is a 7-year Department of Health plan beginning in 2019 and ending in 2025 that uses a holistic, multi-level approach to schistosomiasis control. It emphasizes partnerships, preventative chemotherapy, animal health, snail control, improved wash, and health promotion. By integrating multiple sectors, it enhances diagnostics, disease tracking, sanitation, and local government empowerment to achieve better health outcomes. The NSEP is given a budget of 5.6 billion, and the approach heavily focuses on partnerships of the Department of Health with various departments in the government, alongside local government units and non-government organizations, ultimately establishing control programs and improved management and monitoring. And so we discussed what are the current measures of NSEP. When it comes to human medical interventions, NSEP conducts MDA for schistosomiasis every January, targeting an estimate of around 85% or more MDA coverage in individuals aged 5 to 65 in endemic areas. In some LGUs, MDAs are conducted through a house-to-house distribution of PZQ, and along with that, there are deworming programs that are implemented through both school-based and community-based approaches. However, the success of this, the data that pertains to that, is not available currently, unfortunately. Along with that, we also have environmental interventions done by NSEP, which include grass cutting, malucicide application, and land reformation, wherein land is reformed from wetlands to rice fields. These have proven effective, as seen in Bohol in 2019, wherein schistosomiasis prevalence was reduced to less than 1%. Schistosomiasis surveillance relies on currently fecal analyses using direct fecal smear and CADO-CATS techniques, but their low sensitivity often leads to underreporting of schistosomiasis. Efforts to improve surveillance include training health workers, though its implementation status remains unclear. Additionally, the Medical Teleparasitology Project was launched to connect local medical technologies with expert parasitologists online. However, there is limited data on its effectiveness. Other measures when it comes to veterinary and agricultural sectors is controlling schistosomiasis through the use of malucicides and using competitor snails as biological control, as snails are one of the main hosts of schistosomiasis. Efforts also involve snail mapping, control programs, biannual animal deworming, and mandatory testing of outgoing animals from endemic areas, alongside veterinary public health activities. And additionally, the snail crushing method is used for detection. However, its limited sensitivity poses challenges in accurately identifying infected snails, highlighting the need for something more effective when it comes to diagnostic techniques. There are also measures being done in terms of animal reservoir control. This includes veterinary public health activities in collaboration with the Bureau of Animal Industry and other veterinary sectors, alongside an introduction of laboratory diagnostic techniques for detecting schistosomiasis in animal reservoirs. This began in 2023 and has a variety of tests being done. Now, these tests have shown varied sensitivities, however, some have reached up to 100% accuracy. According to our research, it is not stated which of the three provided are the most successful, unfortunately. However, it has been stated that these tests have been implemented since 2023. When it comes to water sanitation and hygiene, the current measures to combat schistosomiasis include the Zero Open Defecation Program, which aims to completely eliminate open defecation to reduce schistosomiasis transmission. While rates dropped from 10.86% to 5.74% in the years 2000 to 2015, there is no data confirming NSEP's success in achieving the goal of zero open defecation. Some communities receive toilets and water systems to improve sanitation, however, the exact number remains unknown. The National Sustainable Sanitation Plan aimed for 100% sanitary toilet coverage by 2022, though reports on its effectiveness are lacking, leaving its impact uncertain. Now we are able to analyze NSEP through various paradigm analyses. From a health sociology perspective, schistosomiasis persists due to the socio-economic conditions and livelihoods of the affected communities. Those most vulnerable are in poverty, working in agriculture, an industry that significantly contributes to disease transmission, according to Devillion, Gray et al. The environment they depend on exposes them to the disease, making structural interventions crucial. While NSEP includes livestock management and snail control, its implementation remains insufficient. Strengthening these efforts alongside sustainable socio-economic solutions is essential to effectively reducing schistosomiasis prevalence. Furthermore, agriculture is widespread in poor communities where low socioeconomic conditions heighten the risk of schistosomiasis. Children in these areas also face poor nutrition, increasing their susceptibility to the infection. Additionally, limited access to healthcare, clean water, and sanitation wash worsens diseases spread by sustaining schistosome-infected snail habitats. While wash improvements are included in NSEP, stronger implementation is needed, possibly even beyond the program, to effectively reduce transmission and protect vulnerable populations. The health economics perspective looks at how schistosomiasis affects productivity and budget allocation. The disease leads to lost workdays and economic losses. One of the ways to measure this is through the disability adjusted life years, DALY, which calculates the number of healthy years lost due to illness or death. In 2021, schistosomiasis had a DALY of 22,300 in the Philippines. In Leyte, infected individuals lose about 45.4 productive days per year, impacting both their income and the economy. This highlights the link between health and productivity. Without good health, society cannot thrive. Another key issue of NSEP is budget allocation. Are the funds for schistosomiasis programs being used effectively? DOH was given 5 billion pesos, and yet there is no transparency reports of it available to the public online. It is unclear due to a lack of data on the program's impact, and without transparency and accountability, it is difficult to measure success. To improve this, a monitoring and evaluation system should be put in place to track progress and ensure the program is achieving its goal of eliminating schistosomiasis, especially since we are on its seventh year of the program. NSEP's long implementation still faces gaps, preventing full disease elimination. To improve success, we recommend enhanced ecological and economic approaches. A key strategy is shifting from carabaos to mechanization, as proven effective in China. However, since this transition is slow, vaccinating carabaos, shown to reduce human infections by 31%, serves as an alternative, though further research is needed before public rollout. Additionally, utilizing agroforestry methods like planting fast growing trees in endemic snail sites was evidenced from China to be effective in reducing snail density to about zero in about a decade as it changes environment diversity and microclimates. Incorporating these methods would help the ANSA program in targeting endemic environments. Additionally, strengthening partnerships and coordination between the different involved government departments and institutions in ANSEP would help improve the program's implementation. What should these departments do better? To begin, the DOH, as the main champion and overall implementer of NSEP, should enhance its implementation beyond just health improvement, also considering more socio-economic improvements, further weighing into the One Health approach. They could do the latter through cooperating with the DA that should interest improving the living conditions of those with livelihoods in agriculture or aquaculture, such as capacity building and financing, hand in hand with the DENR that should focus on improving the environmental conditions of those with livelihoods in the aforementioned agriculture and aquaculture with the previously mentioned ecological and economical approaches. LGUs, especially those in geographically isolated and disadvantaged areas alongside regions where schistosomiasis is still prevalent, should coordinate with the mentioned government bodies in implementing programs in alignment with the goals of NSEP, such as MDA and deworming, programs focused on improving wash to reduce exposure to the disease, and health promotion and education to increase schistosomiasis awareness and the need for MDA to reduce its surrounding fear and stigma. At the bottom of this, the DBM should be responsible for financing all mentioned government institutions and ensuring budget allocations for the program are used effectively and efficiently. Strengthening such would simultaneously enhance the One Health approach of NSEP and overall improve health systems as a whole. Lastly, involving stakeholders in this program design process through participatory development is encouraged as the success of the program would not be possible without the reliance on the households residing in these endemic communities, as they are the main stakeholders and the grassroots actors of these interventions. Some of them are already aware of the disease and its prevention, evidenced in Leyte, but not all are informed. It is the reality that matters as the program is aimed at them. Thus, they should have a level of participation to address what they truly need, which could also be done through conducting a needs assessment, as discussed in class. Ultimately, to effectively combat schistosomiasis, a comprehensive approach is needed. One key recommendation is to integrate the NSEP into LGU health programs, particularly in GIDAs and regions still at risk. Additionally, policies should be developed to address other factors contributing to disease in collaboration with the relevant government agencies. To further promote transparency and accountability, the program should adopt the results based monitoring and evaluation framework. This approach defines the roles and responsibilities of all stakeholders while setting clear program KPIs, baselines, and targets. This also ensures that findings are reported and used to improve future program implementation, something which the current NSEP lacks. This prevents key stakeholders from being left uninformed and helps identify both successful strategies and areas needing improvement. With us presenting the recommendations for ANSEP itself, we now are going to discuss the limitations and recommendations of us as the researchers behind this presentation. Now, first of all, for our limitations, we had a lack of time among students for collation of information, given that we come from different backgrounds and different years alongside different courses. Next, we also had a lack of available information or resources, especially for ANSEP, as it is a relatively new project. However, admittedly, this is rather disappointing as it shows a lack of transparency from the Philippine government, given that there was a 5 billion peso budget for it and it began in 2019, yet we have no proof of what exactly that money has gone to or whether the proposed and done programs are successful. Meanwhile, for recommendations, we first would recommend more forms of collection of information, this being via interviews with stakeholders or request of progress reports and more, and additionally, more time for research. Thank you. And with that, our presentation is done, and here are our references. Thank you for your time, and thank you for listening to our presentation.